If your chest feels tight, but every test comes back normal, it can feel confusing and honestly scary. You might wonder if something was missed, or if it's just anxiety, even when it feels very physical. Here's the key idea. Normal tests often mean life-threatening causes were not found, not that your symptoms are imaginary. Chest tightness can come from the heart, lungs, muscles, ribs, nerves, stomach, or stress systems, and many of those don't show up on a quick ECG or a basic chest X-ray. Some causes are intermittent, so they hide when you're sitting calmly in a clinic. Others are functional, meaning the structure looks fine, but the system is still reacting. The goal is to build a clear mental map of what can cause tightness, what normal usually covers, and what signs should push you to seek urgent care. By the end, you'll have better language to describe your symptoms and better questions to ask your clinician. Moving to slide 2. First, let's decode what tests are normal usually means. In many clinics or emergency settings, the initial focus is ruling out immediate danger, things like a heart attack, a collapsed lung, or a major infection. That often includes an ECG, blood tests like troponin, maybe a chest X-ray, oxygen levels, and vital signs. Those are excellent for catching certain problems, but they are not a full investigation of every possible cause of chest tightness. For example, an ECG can be normal between episodes. A chest X-ray can look fine even if you have asthma, reflux irritation, or muscle strain. Even cardiac blood tests are designed to detect heart muscle injury, not every type of reduced blood flow or spasm, so normal is reassuring in one way. Major red flags may be less likely, but it doesn't automatically explain what you're feeling. The next step is matching the pattern of your tightness to the body system most likely involved. Moving to slide 3. Now, a quick safety filter. Some chest symptoms should be treated as urgent, even if you've had normal tests before. If tightness comes with fainting, severe shortness of breath at rest, blue lips, new confusion, or coughing up blood, that's not a wait-and-see situation. If you have crushing pressure that spreads to the arm, jaw, or back, especially with sweating or nausea, get urgent evaluation. The same goes for sudden one-sided chest pain with trouble breathing or a fast, irregular heartbeat that doesn't settle. Also pay attention to risk context, recent surgery, long travel, pregnancy, cancer treatment, or a history of clots can change the urgency. The point isn't to scare you. It's to separate needs immediate help from needs a careful plan. Once urgent signs are off the table, we can look at the common, often missed explanations for tightness with normal basic tests. Moving to slide 4. One of the most common normal test causes is the chest wall itself. Muscles, ribs, and the cartilage that connects ribs to the breastbone. This is often called costochondritis or chest wall pain. It can feel like pressure, tightness, or a sharp ache that makes you worry about your heart. A clue is that it changes with movement, posture, or pressing on specific spots. It can flare after new workouts, heavy lifting, long hours at a desk, coughing, or even sleeping in an odd position. Another clue is that deep breaths or twisting can reproduce it. Basic heart and lung tests can be normal because the issue is mechanical, not internal organ damage. The tricky part is that anxiety can rise after the pain starts, making the tightness feel even more intense. Describing exactly what movements trigger it can help your clinician distinguish chest wall pain from other causes. Moving to slide 5. Another big category is breathing mechanics, especially hyperventilation and air hunger. This doesn't always look like obvious fast breathing. Sometimes it's subtle overbreathing during stress, concentration, or after a scary symptom. When you breathe off too much carbon dioxide, your blood chemistry shifts slightly, and that can cause chest tightness, tingling in the hands or lips, lightheadedness, and a feeling you can't get a satisfying breath. Oxygen levels can still read normal, which adds to the confusion. People often respond by taking bigger breaths, which can keep the cycle going. This pattern is common in panic episodes, but it can also happen in asthma, reflux, pain, or after illness, so it's not automatically just anxiety. A helpful clue is whether sighing, yawning, or frequent deep breaths show up around the tightness. That's a signal to look at breathing pattern as part of the puzzle. Moving to slide 6. Asthma and airway irritation can also cause tightness even when basic tests look fine. Many people picture asthma as loud wheezing, but some experience mostly chest tightness, cough, or reduced exercise tolerance. Symptoms can be triggered by cold air, allergens, smoke, infections, or exercise. A chest X-ray can be normal, and you might not wheeze during a clinic visit. The more informative tests are lung function tests, like spirometry, sometimes with a bronchodilator, or peak flow monitoring over time. Another related issue is vocal cord dysfunction, also called inducible laryngeal obstruction, where the upper airway narrows during breathing, often during exercise or stress, creating tightness and a can't-get-air-in feeling. That can be mistaken for asthma, yet asthma inhalers may not help much. The pattern, when it happens, how fast it starts, and whether it's more on inhaling or exhaling, matters a lot here. Moving to slide 7. Let's talk about the stomach and esophagus, because reflux is a classic normal tests chest tightness cause. Acid reflux, non-acid reflux, or esophageal spasm can create burning, pressure, or a squeezing sensation behind the breastbone. It can feel identical to heart discomfort, and it can come with burping, a sour taste, throat clearing, or a lump in throat sensation. Some people don't feel heartburn at all, which makes this easy to miss. Triggers can include large meals, lying down soon after eating, alcohol, caffeine, spicy or fatty foods, and certain medications, without you realizing the connection. The esophagus also shares nerve pathways with the heart, so the brain can interpret esophageal pain as chest. Basic heart tests can be normal because the issue is in the food pipe, not the heart muscle. If your tightness clusters after meals or at night, reflux moves up the suspect list. Moving to slide 8. Some chest tightness is nerve-related. Irritated or sensitive nerves in the chest wall can create burning, stabbing, or band-like tightness. One example is thoracic radiculopathy, where a nerve from the spine is irritated and refers pain around the ribs. Another is intercostal neuralgia, affecting the nerves between ribs. People often notice it's one-sided, follows a line, or flares with certain positions. Shingles can cause nerve pain even before a rash appears, so a new, localized burning pain deserves attention. There's also a phenomenon called central sensitization, where the nervous system becomes more reactive after stress, illness, or repeated pain episodes. In that case, normal imaging doesn't mean nothing is happening. It means the alarm system is turned up. The practical takeaway is to track whether the sensation is sharp, electric, or skin-sensitive, and whether it follows a predictable path across the chest. Moving to slide 9. Now the heart. Because normal tests doesn't always mean no heart involvement. It often means no evidence of a heart attack or major rhythm problem at that moment. But there are other possibilities. Some people have coronary artery spasm, where a vessel temporarily narrows. Others may have microvascular angina, involving the small vessels that don't show up well on standard angiograms. These can cause chest pressure with exertion or stress, and symptoms may come and go. Another issue is inflammation around the heart, like pericarditis, which can sometimes be subtle early on and may need specific evaluation. Even palpitations from benign rhythm changes can create a tight, uneasy chest feeling. The pattern matters. Exertional symptoms, predictable triggers, and relief with rest are important details. If your tightness is consistently tied to activity, it's reasonable to ask about further cardiac evaluation, such as stress testing or longer rhythm monitoring, depending on your risk factors. Moving to slide 10. Anxiety and stress physiology deserve a careful, respectful explanation. Stress can tighten chest muscles, change breathing, and increase stomach acid. It also activates adrenaline, which can cause a racing heart, sweating, tremor, and a sense of pressure or impending doom. The important point is that this is a body response, not you making it up. And it doesn't require you to feel worried first. Sometimes the physical sensation starts, then the fear follows. Panic attacks can peak quickly and feel like a medical emergency. Chronic stress can create a lower, persistent tightness that comes and goes with workload, conflict, poor sleep, or caffeine. It's also common for one real episode, like a scary palpitation, to teach the brain to scan the chest for danger. That hypervigilance can amplify normal sensations. If stress is part of your pattern, the goal is not to dismiss symptoms, but to include the nervous system as one piece of the full explanation. Moving to slide 11. So how do you actually move forward when the initial workup is normal? Start by making the symptom easier to classify. Describe the quality: pressure, stabbing, burning, squeezing, or can't feel my lungs. Note the timing: seconds, minutes, hours. Track triggers like exertion, meals, posture, cold air, stress, or specific movements. And track what helps: rest, changing position, slow breathing, or time. Also note associated symptoms: cough, wheeze, palpitations, throat symptoms, dizziness, or tenderness to touch. This kind of detail is not overthinking. It gives your clinician a map. It also helps decide which next tests make sense, if any. Lung function testing, reflux evaluation, physical exam focused on chest wall, or longer heart rhythm monitoring. If you can, write down 2 or 3 recent episodes with these details. It turns a vague complaint into a solvable pattern. Moving to slide 12. It also helps to know which follow-up questions are reasonable. You can ask, which serious causes were ruled out by my tests and which weren't? That invites clarity without confrontation. You can ask, does my pattern sound more like chest wall pain, reflux, asthma, or something cardiac? You can ask whether a trial of targeted evaluation makes sense, like spirometry for suspected asthma, or a focused exam for costochondritis. If exertion is a trigger, ask what would justify a stress test in your situation. If episodes are random with palpitations, ask about a longer monitor, because a short ECG is a snapshot. And if stress seems involved, you can ask for options that address the body loop: breathing retraining, physical therapy for chest wall mechanics, or structured approaches for panic symptoms, without implying the symptoms are all in your head. The goal is a stepwise plan, not endless testing. Moving to slide 13. Let's close by putting it all together. Chest tightness with normal tests is common, and it often sits at the intersection of muscles, breathing, digestion, nerve, and stress physiology. Normal is good news in one sense. It lowers the odds of immediate catastrophe. But your job isn't to accept uncertainty forever. Your job is to notice patterns, communicate them clearly, and escalate appropriately if red flags appear. If your symptoms are changing, becoming more frequent, or consistently triggered by exertion, that's worth reevaluation. If the tightness is reproducible with touch or movement, chest wall causes climb higher. If it clusters after meals or at night, reflux becomes more likely. If it comes with air hunger and tingling, breathing pattern may be involved. Use that map to guide the next conversation with a clinician. If you want more practical breakdowns like this, subscribe. And in the comments, share which pattern fits you best: A, exertion, B, meals, or C, stress and breathing. This information is not a substitute for